For most people, the physical danger of heavy drinking is synonymous with a single organ. We assume that if alcohol is going to kill us, it will do so by destroying the liver. A landmark registry study out of Denmark recently tested that assumption on a massive scale. Researchers followed 47,800 individuals entering treatment for alcohol use disorder and matched them 1 to 10 against nearly 500,000 people from the general population. Over a 10-year follow-up, 18% of the individuals in the alcohol treatment group died. This was 4 times higher than the mortality rate of the matched general population. Although the total mortality was 18%, only 2.1% of those deaths were caused by alcohol-related liver disease. The remaining 15.7% of the cohort died from causes unrelated to liver failure. The liver is alcohol's most famous casualty, but in the context of mortality, it is a decoy. To account for the other 15% of deaths, we have to look at how alcohol acts as a systemic, whole-body killer. This discrepancy is driven by competing risks. Liver cirrhosis is a slow-moving condition that often takes decades to become fatal. For many with severe alcohol use disorder, other lethal factors are mathematically more likely to claim their life before the liver ever reaches a point of clinical failure. The individuals in this study entered treatment at a median age of 46, usually with 20 to 25 years of heavy drinking already behind them. This is the precise window where long-term alcohol exposure begins to violently collide with failing middle-age biology. The data reveals that the 18% mortality rate is driven by 3 specific buckets of excess death. First, metabolic synergy. Second, external trauma, and the survivability gap. Alcohol use disorder functions as a systemic vulnerability multiplier, breaking down the body's defenses from multiple angles simultaneously. While liver disease isn't the primary cause of death for the majority, its lethality changes when combined with other baseline health factors. The study identified a critical comorbidity that accelerates this risk: the collision between alcohol use and type 2 diabetes. This chart shows the 10-year risk of developing and dying from liver disease. For a patient in AUD treatment without diabetes, that risk is 7%. But if that same patient has type 2 diabetes, the risk nearly doubles to 13%. Alcohol weaponizes existing metabolic disorders. It strips away the liver's resilience, turning a long-term risk into an accelerated, immediate threat to life. Half of the excess deaths identified in the study had nothing to do with internal biology. Instead, they fell under external and other alcohol-related causes. In the language of epidemiology, the term external causes describes fatal car crashes, accidental poisonings, drownings, and suicides. The 10-year risk of dying from one of these external events was 2.7% for the treatment group, compared to just 0.4% for the general population. Alcohol's neurotoxic effects dismantle an individual's behavioral and environmental defenses. Trauma often kills these patients before their organs have the chance to fail. The final driver of the mortality rate involves standard illnesses like cancer and cardiovascular disease. These panels show the cumulative incidence of cancer and cardiovascular disease. Note how close the lines are. Over 10 years, the group in alcohol treatment developed these diseases at roughly the same rate as the matched general population. Despite getting these diseases at similar rates, the patients in the alcohol group were 2 to 3 times more likely to die from them. This survivability gap exists because chronic alcohol use compromises the immune system and the body's overall resilience. Patients often cannot adhere to or physically survive the rigorous treatments required for cancer and heart disease. In this context, alcohol turns manageable or treatable diseases into death sentences by destroying the body's ability to recover. Alcohol use disorder operates as a whole-body crisis. It attacks through metabolic synergy, external trauma, and compromised survivability. Because these threat vectors are so diverse, advising a patient to simply stop drinking is an inadequate medical response to the actual risks they face. The study suggests that the moment a patient seeks treatment for alcohol use, they require immediate, comprehensive screening for cancer, cardiovascular health, and metabolic disorders, not just a liver panel. For the median 46-year-old patient seeking help, the 18% mortality rate represents a ticking clock. To improve survival, the medical response must be as comprehensive and systemic as the lethality of the disease itself.